Welcome to the village. Alright, for today's episode, I'm really excited to have Heidi Gadoy. Heidi, why don't you introduce yourself, give everybody your background, and why you are an important person for me to talk to.
Awesome. Well, thanks so much for having me. So my name is Heidi Gadoy. I am a gynecologist. I work in Albany, New York, and I just started my own practice doing gynecology. So what does that mean? So I take care of women who have different types of GYN cancers, but also complex GYN. I also give chemo, but I also see lots of normal, healthy women as well. I grew up on Long Island, and then I went to Cornell for my undergrad.
I didn't realize you were a downstate girl.
I was a downstate girl. 4 years at Cornell, and then I took 2 years off because I wasn't sure if I wanted to get my PhD or my medical degree. So I took 2 years off, and I went and worked at the NIH and the NICHD, the National Institute of Child Health and Development. And I did basic research on premature ovarian failure and polycystic ovarian syndrome, and looked at some of the genetic causes for that and some of the treatments related to that. And then I got accepted to med school. Ironically, I got accepted the day before med school started, and so I had to pack off all my stuff from Washington, D.C., and I moved to New Jersey, and I stayed in a hotel for a couple days until I found an apartment. And then I went to UMD&J in South Jersey. I'm an osteopathic physician.
Yeah.
And so I got my DO from there. Then I spent 4 years at Georgetown doing my OBGYN residency. Then subsequently I spent 4 years at Roswell Park doing my gynecology fellowship, where I get additional training in surgery and in chemotherapy and how to care for some of the most sick patients that we have.
So you've seen a lot.
I've been to a couple of places, yeah. I truly enjoy it. I think most people who go into OB really love the baby side of it, and that was my story as well, because it's so different when you do this in med school, right? So you're dealing with lots of sick people, you're learning a lot of disease, and when you go into a field and you're like, all these people are healthy, and it's just like one of the most natural things that you can do, right? Having a baby, like from the start of time, that's how we started, right?
Yeah,
having
that's
babies.
why we're in existence. Like,
Exactly.
Lots of babies being had.
Yeah, so I thought that was really cool, and I got to deliver a lot of babies on my rotation, and I loved it. And so when I finished med school and matched at Georgetown for my residency, I thought I wanted to be a high-risk maternal fetal medicine doctor, because I loved it so much. And as my time as an intern, which probably is one of the hardest years of your life.
Oh, yeah. Your entire life.
Yeah. Your internship, you're free to like order Tylenol, right?
Yeah.
So
that's exactly what I thought. We had an orientation right before our first year of residency started, and I heard the residents signing out to each other the Tylenol they ordered, and I was so freaked out.
Right?
I was like, I'm going to be doing that.
And you're like, I have to make sure the dose is right. I mean, you were dealing with small, tiny people.
Yeah.
I was dealing with like adults. So that kind of was stressful for me. Over the course of the year, I realized it wasn't the babies and the delivering the babies, because you know what? The reality is, you go to China and women squat in the field and they have their babies, and most babies are going to come out fine. But it was actually the women's health that was more interesting to me, kind of getting back to my roots when I was at the NIH. How do you care for these women? Where am I going to make the most impact? And so specifically, I remember a patient who, she was very young. She was in her mid to late 20s, and she had cervical cancer. And so she was actively dying. And so how was I going to make the last 6 months of this girl's life good? How can I impact that? And how can I make her time on earth the best? And that really kind of stuck with me. And I almost left OBGYN because I thought that I wanted to make a different impact and do something like cardiology. But then I subsequently had a surgeon who was a gynecologist kind of took me under his wing, and he brought me to the OR, and he said, Heidi, you're really good at this. I want you to think about this field.
Yeah.
And then from that moment on, like, it was my goal to kind of really provide excellent care for our moms, our sisters, our grandmas who were sick.
It's true. They're our sisters
They
and
are.
grandmas, and it's scary too, right? Like that fear that women have for their health.
Mm-hmm.
So that kind of fear that they need that excellent care, that they deserve that excellent care, right?
And they need somebody to listen to them.
Yeah.
And so my job is to be a really good listener listen to the small differences in words they use. I also am a very observant person. I see how they sit at the table, how they like hold their body, how they move. I try to watch them walk into their exam room so I have like a really good idea of their mobility and like what's really bothering them, and then try and use that to ask very pointed questions.
Yeah, as we say, the physical exam starts the minute you enter the room.
100%.
Right?
Truly,
Yeah.
Like take us back to like our first day of med school,
Yeah.
right? In physical diagnosis, where you're,
Right.
Yeah, and you just look at the patient. That's one of our best like things that we can do. We know who's really sick, right? So one of the ways we sign out with our colleagues is, does she pass the look test? Can she go home? Does
yeah.
you know what I mean? Like,
Yeah.
and you're making those quick assessments and those judgments immediately. How is this patient doing? Does this person need to be admitted to the hospital? I'm sure as a pediatrician you see this somebody, especially during like the flu respiratory season, you kind of see people that are like breathing really heavy. They look like they're a guppy, and you're like, oh, this person doesn't pass the look test.
Yeah.
And so that was one of the things. The other thing about you in oncology is you're able to provide full circle care. And what does that mean? From start to finish. So I take people who maybe just come in with an abnormal pap smear, turns out to be cancer, then I operate on them, they need chemo, and then if they're going to move on to like the next stage in their hospice, so I get to do their palliative care, I get to do their surgery, I get to do their chemo for really 5 disease sites. So it is really very intense, and most people in their life don't get to have a relationship with their physician like this, caring for them for every aspect. As a GYN oncologist, we're also considered really good problem solvers. So we're able to figure out, all right, why is this, and put pieces together where a lot of people kind of just look at this patient dumbfounded and they don't understand some of the really complex disease processes that are going on. Just because as a GYN oncologist, you're kind of seeing everything. You're like the trauma surgeon of the pelvis.
Yeah.
Because one of the most complicated surgeries that we do is something called a pelvic exent, where we take the colon, we take the bladder, we take the uterus, we'll take lymph nodes, we'll take the ureters and cut them and reimplant them. So one of the most complex surgeries, and a GYN oncologist can kind of cover all of that. So it's really a very subspecialized field. About 1,200 GYN oncologists practice in the United States. I'm really proud to be one, and very excited to be here to kind of talk about not just GYN oncology, but also about other issues that affect women across their lifespan.
Exactly. You said it right there. Your whole lifespan. Everything starts as a child, and we are in that same body your whole life. So it does start from the basics, the building blocks of your little life as a little girl, and where it takes you from there. So I'm honored to be here with you.
Oh, it's my pleasure.
You know so much. You have so much to share. And one of the most special things about you is how much you care. I wish everyone could see it on your face.
I love my patients. They are, I think when you find the field that you're supposed to be in, and you're just so comfortable in your own space and in your acumen. Somebody once told me that there are 3 A's to being a doctor. Affable. You have to be a nice person.
You do.
You have to listen. You have to be available. Unfortunately, like I miss some stuff with my kids because I'm available to my patients, and you have to be able. You have to have good training. You have to have confidence in your skills. And those 3 things really are like a trifecta. I think that it's really important that you make that known to people, that you are able, you are available. And I never say no.
Yeah.
Because saying no means that there's a patient behind that, right? So there is a person.
Right.
And so like, am I going to let somebody go to somebody who's less capable? No.
Right.
No, because that's a human being, and it could be, like I said, my mother, my sister, your sister. You know what I mean? Like, the world is small. So you want to be kind and do what you took your oath to do.
Yeah, exactly. We did take an oath.
We did.
Right?
We do.
You have to care about the person. Health is so scary.
I think sometimes it's hard to kind of wrap your head around. I think as a doctor, we have a really good idea of some of the bad stuff that can happen, right? So when we have medical issues, we kind of are thinking 5 steps ahead. Oh,
Yeah.
This is it. But I think that one of the most important things as a physician is to be a really good steward for your patient. Be there, a really good guide, a mentor. And we're in a day of medicine where we don't do this paternalistic type of medicine, right? So we don't tell them what to do. And we try to make like shared decision making. And I'm sure you do this with the parents. And as the children kind of age and become adolescent, you kind of try and bring them into the decision making process. But kind of making joint decisions as opposed to 20 years ago, this is what you're going to do, blah, blah, blah. You know what I mean? 1, 2, and 3. And so the way we practice medicine has changed. You know?
It really has. Yeah, the doctor isn't like the be-all. They're a person who's there to help you, guide you, and make the best recommendations for you or your child with a discussion. Yeah. There's a lot of talking. Mm-hmm.
I think more talking now than there's ever been.
Yeah.
You know? Yeah. And Dr. Google, it makes it really hard too.
Yeah, because you have to untalk Dr. Google and then say what you have to say.
Yeah.
Right.
And I try to be really proactive and have printed literature for my patients.
Right.
Because I feel like there's so much unregulated stuff on the internet, which great, First Amendment, freedom of speech. But the N of 1, where Susie had this experience, doesn't necessarily pertain to everybody.
Right.
And so in that regard, I try to give them safe websites to go to, sites that are going to give them the most amount of information without having to click on to, you know, a million ads and kind of get lost. And now they're looking at, you know, the Roomba.
One thing. Right. Yeah, exactly.
They're looking at a Roomba. And wait, I was looking at, like, when to expect my daughter to get, like, her first period.
Yeah, now I bought a Roomba off of, like, a third website.
Exactly.
And now I need to go to Target.
Exactly. I got to return something.
Right.
So I think one of the really important things to talk about is how do we educate our daughters?
Yeah.
How do we start educating? And I think that starts at home. Okay, as the mother of a 7-year-old and also of a 6-year-old boy. I have a 7-year-old daughter and a 6-year-old boy. I try to use the correct terminology for our anatomy. I think that's number one. It's not hoo-ha, it's not kitty, it's not...
That's interesting. I was told one of the maternity nurses had encouraged that as well. Mm-hmm. So that's interesting because in pediatrics we're so used to saying owie and, you know, everything's a different... term.
They know the anatomical term for it, so that if they have an issue, they can say, "Oh, I have an itch on my anus," or I try to make them very educated about their body parts. And so, how do we do that? And I think that starts from just talking to your children. You don't need to talk baby talk to your children. You can talk to your children in an appropriate manner using the terms that are appropriate, especially when they go to school, so that they can also, you know, show that they know the correct terms. They can talk to their teacher about it. And also that you can ask them if there's any concern about anything going on, or everybody has the kid that pulls down his pants. So you know what I mean? Like, you can have these conversations. And so one of the things that I use is a book that really just shows basic anatomy. It's kind of a pop-up book. It has flip pages. They can open a thing, and my 7-year-old daughter can read very well, so she can read that to my 6-year-old. She reads it to me, and we kind of talk about what it means. And so we try to just have very frank conversations about our body, and we try not to shame our children about their bodies. You know, I think a lot of people struggle with, does your child see you naked? Does your child, you know what I mean? Like, and I think that it's natural for them to see you if you're in the shower and they come into the bathroom. Don't hide, you know, it's not a hide. They need to understand what their body is going to look like. You know, they have questions. And so answer these questions as they ask them. Okay. I don't think it's appropriate if you're, 15-year-old sees you naked, but like your 3-year-old, your 4-year-old comes in and sees you showering. I think that's, as a mom, you're showering with the door open so you can hear everything going on.
They probably need something. You have to be multitasking while you're in the shower.
Yeah. So I'm like making my, my lists, my, combing my hair or whatever. So. Yeah,
right.
So
you have your phone in there with you, making appointments. So your hair is
totally, and you're like you're deep conditioning or something, or you bring your kid in your shower with you because you're like, all right, 2 birds, 1 stone. Like, I need to get clean. This child needs to get clean, and you can like talk about body parts at that point, and it doesn't need to be so formal. But I think it's really important that children know the correct terminology for body parts, that kids understand. Mommy has different parts than daddy, and that as well.
I know with potty training, we always say the pediatricians, American Academy of Pediatrics recommends you having your child in there when you're going to the bathroom, and they can learn what the process is of going to the bathroom.
Yeah.
A similar thing, they have to see to understand.
Mm-hmm. Most moms will tell you that they don't pee with the door closed. You know?
Yeah.
Yeah. So like this is a normal kind of way that we are teaching our children about their bodies and how they work. Another important thing is the school offers, I think it's in the 4th grade, is usually when they start talking about when you start your period, when to start thinking about having like a period kit, how your body works, and ovulation and menstruation and breasts and body odor and things like that. And I think that it's important to like take what the school does, but also you need to do your own thing from like a GYN perspective. What are the expectations? What you want to set your child up so if they do start bleeding at 8 and you're kind of a young to start menarche is what it's called, or their menses, that you're prepared and your child is prepared and not like completely taken off guard.
And scared.
Yes.
I mean, imagine seeing that in your underwear and never expecting something like that to happen.
Yep.
Is that too young?
8 is not too young.
Okay.
It's on the lower range of things. Average age can be about 12, they usually say. If you're going past 16, that's something that you also have to check out. You also have to look at the child. Athletes would tend to be on the thinner side, on the leaner side, and they may turn out to be a little bit undersuppressed. Their hypothalamic pituitary axis might be suppressed from having such a lean body mass that they might not have the capacity to start menarche. They don't have enough fat in their system to kind of trigger all the hormonal cascades to start a period. And so that's another issue to, amenorrhea or lack of a period because you're too skinny.
Yeah.
Or if you're bulimic, if you're anorexic, you might not get your period. So I think moms have to be kind of on the lookout for all these things. Hey, my daughter's 14 and she hasn't started her period and she's super thin.
Or dads, or grandmas,
Or dads,
some of the...
everybody, yeah.
Or the doctor. You see, the primary care, the pediatrician, or whoever your primary care provider, it's important to ask these questions.
Yeah.
I like to ask the questions that every time I see a child that's either somewhat developed at age 10 or so, or a teenager into their 13, 14, you ask about the period and make sure, because every now and again, you'll have a girl at 16, looks like she's a fully developed woman. I have one in practice, and she's never had a period.
Mm-hmm. And so you're worried about androgen sensitivity, right? And so you're going to need an endocrine workup. And so you're going to need an ultrasound, see if she even has a uterus.
And we learn about these little possibilities in med school. And how often do you see them? Like not having the parts that you thought you had?
Not often.
Okay.
They're really rare. Okay, but it does happen. There are 250, 300 million people living in America. That's kind of the people we're seeing, right? So what's the frequency? Maybe one in a community. So like one in a couple 100,000. So not common. Okay, so menarche or start of menses around age 12. Before that, you're going to see some breast budding. So you'll see a mound on their chest. They'll start to get small breast buds. You might notice that they have some body odor. You also may notice that they're going to have some hair underneath their arms, and they may start to get pubic hair as well. I mean, these are all kind of some of the signs that your daughter is starting to mature and her hormones are starting to kind of start to pulse like you need to have a cycle. Now, I think when we talk about having a cycle, it's very different than even 20 years ago in terms of what are the products available for our girls. And I think that is really an important thing in terms of tampons, pads. Those are kind of like the old standby. Now we have period underwear that girls can wear at night. They don't have to worry about, leaking in their beds. They can wear them to school. They don't have to wear pads. They don't have to wear tampons. And it's absorbent enough that their flow can be absorbed into these underpants. And they're dark colored and you wash them. It's like a liner in the underpants. And it's very popular. I think
I saw them on Facebook.
Yeah, me too. And Amazon too.
Yeah.
So they're very popular. And I think that they have, for girls that are very active, sporting, and really kind of don't want to have a bulky pad or can't put a tampon in, it's not comfortable, then I think that it's a really great option. Also, I had read this article on Facebook. It was actually, I'm on this Physicians Moms group.
Oh,
and
cool.
So they were talking about my daughter had missed Days' swim class because she was on her cycle. And so she had to make up these things. And so they make swimsuits with this same like technology that locks in the period blood and the menses.
Yeah.
And so you can go swimming in it and you're not wearing a big bulky pad. You don't have to wear a tampon.
Right.
And so it really, I think, has changed some of the culture and the stigmatism that is associated with
to
getting
be
your
left
period.
out of your activities because of a period, which is something that comes and happens every month, and you have to keep living your life
Right.
with a period, and we don't want to teach our girls that life stops.
Or that it's a hindrance, or that it makes you weaker, or it makes you less.
Yeah.
It is normal and it is a functional part of your body. And the period is there for a reason, right? So when we ovulate, our ovaries release an egg that then kind of goes into the fallopian tube and down into the uterus, where the lining of the uterus should be very lush at this point before you get your period, and this is where you would then have a sperm come and fertilize the egg, or the zygote would then implant in this lush endometrium and have rich nutrients to grow. Okay. Now, if we think back a millennia, girls would have babies at 13, 14, 15. People really only live to their 40s, right?
Yeah.
So like
that's good to know.
Yeah,
Sitting here.
So they did have babies at 13 and 14,
Yeah.
and middle of life was 20. You know what I mean? So
yeah.
it was a different time.
Right.
And so our bodies adapted to that, okay? And that was the norm. Now, it's not the norm to have a baby at 13, 14, 15. The average kind of age of having a child is the late 20s. So that number has shifted almost 2 decades now, right?
Yeah,
So,
and it keeps shifting to
It does.
older and older age groups.
Absolutely. I think we have to prepare our kids to understand why it happens in today's society. It is not the cultural norm to get pregnant at 12, 13, 14, 15, or even in your teens. Okay? And I think that's one of the things that we're going to talk about is how to manage period pain, how to manage your cycle, how to avoid pregnancy, and how to kind of thrive. Okay? Not just survive your period.
That's one of the big questions I have for you. As a pediatrician, I see patients into their college years. So I see a lot of patients with their period. Many do complain of this period pain, or they either complain about it as bothering them, or on the other hand, they don't know what to do about it. They just don't bring it up. So there's any extreme or anything in between those two extremes of not being able to deal with the pain at all, or dealing with it more than they should have to. So talking about the period pain and what it means, why it happens, how to control it, and when is it too much?
Good questions. So let's talk about a normal cycle. A normal cycle will come every 28 days. You should bleed maybe a little spotting, like a half day, then your heavier flow. For 2 days, a heavier flow, then a medium flow, and then a light flow. Period should last between 5 to 7 days. You should not be changing a tampon or pad every hour. If you're soaking a tampon or pad every hour, that is considered too much bleeding, and you could become anemic. And that's one of the things that can hurt our girls, right? So when they become anemic, they're fatigued, probably not at their best, and they're hemorrhaging. They're essentially hemorrhaging out of their body, and it's pathophysiologic. It's pathologic. You're not supposed to bleed that heavy.
You're losing blood, you're losing hydration, and you're losing iron.
Yes.
Which we need to carry oxygen to our body, to
Absolutely.
our vital organs. Yeah.
Yep. So required for us to function, we need to, as primary care doctors, pediatricians really have a tough job of kind of asking all these questions, right?
So many questions at this age.
Yeah. And then really kind of doing everything else. And so it's like a whole nother layer of medicine that kind of gets added on once a girl hits puberty and starts menstruating. Average age of menarche, or to start your period, is age 12. Don't expect to cycle every month when you start your period. Your hypothalamic pituitary axis, which is that little piece in your brain that makes all these hormones, does not become mature for 12 to 18 months after you start your cycle. It's not uncommon that you can get your cycle and then not get another cycle for another 4 months. And so it can be a little bit wonky, and it can be not as predictable as we would like in the beginning.
And sometimes I've had a couple girls who've had sort of a period at 8 or 9 and go another year or two and don't really start it again.
Yep, because maybe their pituitary axis was not mature enough to start their cycle, or to continue this pulsing that we need to kind of get us regular. So a couple of years it can take to become regular. Dysmenorrhea is a word that we use to say pelvic pain or period pain or pain surrounding your period. Okay, so it's not uncommon that your uterus is going to contract because it's contracting to shed that lining of your cycle, of your menses. So that's a shedding of the lining once the hormones built it up. You didn't get pregnant this month, so we're going to shed that lining. Okay, and we're going to start all over again. And so as you shed that lining, your uterus contracts, and that's what's causing the cramping. Okay. Often things that you can do to control the cramping: hot showers, baths. You can use a hot water bottle, but you also can use NSAIDs, non-steroidal anti-inflammatories. Motrin, Aleve. They also make Midol. They make other types of medications kind of geared towards your period.
Do you like Midol? I don't like it for the girls.
I tend not to use it. Yeah. I think just straight Motrin is fine. Yeah. And it's really going to cause that cramping and that prostaglandin release to decrease.
Really attacks the chemical that's causing it. And that's why we say not really Tylenol. You don't want to use aspirin in children.
No, especially and if you have a girl that's bleeding a lot, you certainly don't want to use aspirin because it can cause her to bleed more. And we also worry about Rye syndrome, right, with aspirin in children. So, that brought me back to like 1985 or something.
We're reminiscing a lot today.
A little bit. Really treating what the issue is, okay? And so if you're missing multiple days of school, that's not okay. Okay? If you feel like you're very anemic, you have pale mucous membranes, what does that mean? Your skin is pale. You pull down your eyes and that pink part's not pink. It's like a pale pink. That's not, if you can't get up without being really dizzy. Those are all symptoms. Or you can't play your sport. Or you're just bleeding more days out of the month than you're not bleeding. Those are abnormal signs. You should make an appointment with your pediatrician, and if they feel comfortable, they'll address it. If they don't, then they will send you to a gynecologist. There are many adolescent gynecologists who kind of deal with this, deal with young girls starting their period and having pain with their period, excessive bleeding with your period, not functioning with your period. And I think that moms of daughters of this age and dads of daughters of this age also will notice that these girls will start having a lot more mood lability. Highs and lows, and so real high highs, real low lows, and it's kind of like hard to control it, because your body is like one big hormone ball.
It's like a roller coaster.
Yep.
The hormones affect your mood. If you're tired, it affects your mood. If you're in pain, it affects your mood. Yeah, that's all happening.
Yep.
Is there anything they can do for these moods?
I encourage people to keep their kids active. Physical activity is good for this. Ask them about their bleeding. Ask them about their fatigue. Ask them to make sure that they're not in one of the extremes. You got to talk to your kid. It might be uncomfortable for you. Okay? And I think a lot of parents struggle with, you know what I mean? But you got to engage your kid, because if you don't know what's going on, they don't know what's going on, and they're asking their peers. So what is another 12-year-old telling another 12? You know what I mean? Like, don't go in the water when you have your period because a shark will eat you.
Right.
You know what I mean?
Something
like
that their grandma
crazy.
Told them just because they wanted to.
Yes. I mean, I remember hearing that story on like Judy Blume or something. Don't go swimming because a shark will eat you.
Right.
No.
You can't. You're right. Exactly. You can't go swimming, and actually that's why I do really try to question these kids about everything, because I don't know if the mom works nights and she doesn't have the time, or the kid is hanging out with the friend whose grandma told them the same thing as the Judy Blume shark story. Like, I don't know what's going on with this child. So it's good to talk to your pediatrician. I bring this point up every episode almost, like, talk to your provider, talk to your doctor. Talk to your medical provider.
Here's the other important thing. If you feel like you're not being listened to, you need another provider.
Yeah.
That is like number one thing. Know that your doctor is available to you and affable to you and able to take care of what your kid is going through.
Yeah.
So it's okay to ask questions. We encourage asking questions.
Yeah.
Because the more questions you ask, then the better sense that I'm going to get about your child. It's uncomfortable for a lot of people, but if we start making it normal, everybody goes to the bathroom. Every girl, majority, get their periods.
Yeah.
So everybody's bleeding, everybody's pooping, everybody's peeing. So
and hopefully everybody's showering.
Yeah, you hope right. That's the other thing. Like, you want to bring up hygiene at this time. How do you keep yourself clean? How do you make sure that you are not, sometimes when your hormones are kind of raging and you just start cycling, you're going through puberty, you're really going to start getting stinky. And so talk about deodorant. You want to talk about showering, wearing clean clothes. Those are really important things, as you're kind of starting to cycle, that you're going to experience, oh my God, I'm extra sweaty or I'm extra smelly. And that's a sign that you're going through puberty.
And keep things with you. Like pack your child a little puberty bag, for lack of a better term.
And put it in the bottom of their bag.
Yeah.
And it doesn't need to be a big thing that they have to share with everybody.
Yeah.
But they're
travel
prepared.
deodorants.
Yeah.
A little something for the middle of the day.
Yeah.
No matter what you do, sometimes in the middle of your school day, you're going to be stinky and you're going to be embarrassed about it. Mm-hmm. That's one less thing you should have to worry about at that age.
Absolutely. Let's talk about the pathophysiology, the bad stuff that can happen.
Yeah.
Okay. What happens if you start bleeding really heavily? Well, one period doesn't make heavy bleeding. But if this is like a constant thing that happens to you every month, then that's something to bring up to your parent and let them know that you're bleeding so heavily. You might get started on some iron because, like we said, you're losing iron. And that's some of your oxygen-carrying molecules in your body that help you function. They give your brain energy, they give your oxygen to your lungs, they feed your tissues. So you really need oxygen to do every part of your daily activity. And if you're bleeding so much and you're losing so much iron, then you're not going to have the oxygen.
Yeah, and that's why you're going to be more tired and feel like you're going to faint sometimes.
When you stand up or like you're running the school mile and you can't do it because you're going to faint because you're bleeding too much. Anemia is an important side effect to know about. And so how can we control that? Well, there are a couple ways that we can control that. We can give you some medication to decrease how much you're bleeding. And how do we do that? And that's in the form of hormones. And so sometimes these would be called oral contraceptives or OCPs, but it's also a way to control your cycle, and we use them as cycle control. So you're not bleeding so heavily. So you're not going to be missing the mile run. So you're not going to be missing going to birthday parties because you're hemorrhaging through your clothes at night. So it's really important to let your parent know or your guardian know that you're bleeding this heavily. Okay, so more than a pad an hour is not normal, or if you have any of the symptoms of lightheadedness, fatigue, you feel like you're pale, or you just kind of notice you're changing your pad every hour, those are reasons to really talk to your parent and let them know that something's wrong and that you need to see your pediatrician.
And keep an eye on if your child feels more tired or looks more pale.
They're not engaging in normal activity. Teenagers do all sorts of crazy things, right? So get in their room.
Right.
Do their laundry. See what you're seeing. You know what I mean? Like, I think if you keep your eyes open, then you're going to have an idea of what's really going on with your kid.
We always say this for so many different things.
Right? Like phones, like this.
Yeah.
But, all these kids have phones. Also, I encourage like a period tracker. It's an app that you can download on your phone and just have her keep track of when she's getting her cycle so that you can review it with her. Hey, did you really bleed for 14 days?
Yeah.
Like, I didn't recognize that. Let's talk about that. Was it? And you can get some information about their cycle as well. So the other really important thing is there are other types of hormonal control. There are things called a long-acting contraceptive device, but also provides cycle control, and that's called a Liletta or a Mirena IUD, which is a little T that gets inserted into their uterus and can put out some hormones locally so she doesn't bleed as much. You can get an Implanon put in your arm, which secretes a small amount of hormones. People tend to bleed a little bit more on that, and it's an implanted device in your arm, so that might deter people. You have things called a hormone patch, where you just slap a patch on your skin. You avoid taking a pill for somebody who doesn't want to take pills. Also provides good cycle control.
And you change it every week?
You change it every week. The issue with that is that you want somebody who's probably under 200 pounds because dermal system has to go through adipose tissue. So be mindful that if you're heavier, that it might not be as effective. Another really great form of birth control is something called a NuvaRing. It's a ring that gets put into your vagina. You place it into your vagina and you pull it out every week. Once a week you pull it out. So you don't have to worry about it for 7 days. It's easy, and then you change it. And then you have, most of these have a week where you get your period and have a withdrawal bleed, which is normal. And so you still feel like you're cycling, but you're no longer cycling when you're on a contraceptive or a pill or a patch. You're not cycling. So you're not kind of going through those ups and downs. And so you may see some leveling out of their mood lability, their periods should be a lot lighter. You're no longer ovulating. You're no longer going through that cycle of highs and lows of your hormones. So it may be beneficial for some of the patients that are really having a lot of PMDD. So if they have a lot of symptoms surrounding their period, it might mitigate or decrease those symptoms.
So instead of a regular PMS, it's more like almost like an anxiety or depressive disorder, this PMDD.
Yep, which is very debilitating. It can be debilitating for these teenage girls.
There's anger, and there's a lot of just that anxiety feeling that hormones do impact.
Yep. And I think it's hard enough going through your adolescence.
Yeah.
And then you're having this secondary issue on top of it.
Yeah. Everybody's hormones are different. And it's a real thing. I actually, in my college years, I was very interested in gynecology. Just the subject matter of it, I still find interesting. That's why I do like to talk to my patients about the gynecology aspect and handle it to my ability, because a pediatrician is only so capable. After that, I don't have those 4 years of gynecology training. Just throwing that out there to keep that in mind too, of who you ask for help for what. Okay. So in college I did do a couple of presentations around women's health for my chemistry major, which I figured out a way to incorporate that interest into my major.
Into chemistry,
yeah.
Okay.
I figured out a way. I was just talking to my class about this real premenstrual, and I was trying to educate them about how it's real. It's not a joke. It's not funny. Ha ha. Oh, she's off mood because of her period. It's not funny. It's real.
It's debilitating.
It's debilitating, and nobody actually wants it. It's not an excuse. I'm sure any female would rather be in a good mood and be able to get on with her day than be going through this emotional upheaval.
Yeah, and really affecting your quality of life and how you see the world, and you're in almost like a fog with it. That's what people have explained, they don't feel like themselves.
Yeah.
It's definitely a treatable medical condition. So if you feel like your child is really running the highs and lows surrounding their cycle, talk to somebody about it, because it's treatable and manageable.
So I've read and kind of heard from other people, nurses and such, about some natural supplements for those who either didn't like how the pill form of a hormone or the pharmaceutical version of a hormone doesn't quite agree with some people. They don't like how it makes them feel, or they have blood pressure issues or a smoker or contraindications to taking something, if I got that correct. Or they just want to try something quote unquote natural.
So natural is hard. So natural is not regulated by the FDA. Natural is you can have 5 milligrams in one tablet and the other tablet has 25 milligrams. Right. So it's not regulated. Our body is this perfectly designed machine that once we start adding hormones and supplements, we can really throw it out of balance. And so specifically, if you're taking a supplement that just has estrogen and you have a uterus, it's called unopposed estrogen, and you can increase your risk of uterine cancer. You can increase your risk of blood clots. So there's a lot of things that you can do by taking unregulated amounts of these supplements. So I don't encourage that, because none of that is regulated. What I do encourage is there are compounding pharmacies you can go to that can make you compounds of hormones that may be more natural than the pharmaceutical brand. But I will tell you that Premarin is made from horse pee. So that's pretty organic compound, right? I understand that you don't want to put anything foreign in your body. You want to be as natural as possible. But we're living in the 21st century. And if we have the capacity to make your life a little bit easier by you not hemorrhaging every month or you not kind of going off the deep end once a month, then I think that it's our job to kind of help you to that process.
I think a lot of parents and some teenagers worry that they're messing with their future fertility.
Has no effect on their future fertility. Girls are born with the amount of eggs that they're going to have for their whole life. They start off with millions and millions, and by the time they get to the start of their period, they have about 400,000 or 500,000. And then over the course of the next 25 years, 30 years, they're going to run through those eggs. And when those eggs run out, you're done. Okay. So
time's up.
Yep. And so as we age, those eggs get older as well, because they've been with us our whole lives, right? Mm-hmm. So that's why when we get older, like greater than 35, greater than 40, that's when your chance of having fertility issues increases. The egg quality has declined compared to when you were 15 or 20. With men, it's a little bit different because they can have babies into their 80s, right? So they are not born with, per se, the number of sperm they're going to have for their whole life, and it's something that they generate from their, primordial cells. They can have babies until the day they die. Women, we cannot.
Right.
So one other topic I really wanted to talk to you about was HPV.
Yes.
Human papillomavirus. Human papillomavirus is what causes cervical cancer, causes head and neck cancer, 100%. Okay, maybe there's a 0.1%, 99.9%.
Head and neck cancer.
Head and neck cancers.
Wow. I don't think anybody really thinks about that.
No, they don't think that I have tonsillar cancer, I have tongue cancer, HPV mediated. Okay, cervical cancer, HPV mediated. Vulvar cancer, about 50% are HPV mediated. HPV is a virus that we pass between each other. Okay. When we look at how many people have been exposed to HPV in their life, it's about 80 to 90%. It is a virus that you get exposed to, and the majority of people clear the virus. But if you don't clear the virus for whatever reason, one, you might be immunosuppressed. So immunosuppressed means your immune system is low. It might be due to HIV causes immunosuppression. You might be on some steroids that causes it, or some medication that causes it. But there are also people born with just suppressed immune systems. There's a combination of your environment and your genes that really kind of is put together, and those people that are at higher risk or people that are more susceptible to this virus will hold on to this virus longer, and it gets incorporated into their cells. And so if this virus gets incorporated into the cells, it can affect the cellular machinery of those cells and cause abnormal cells. Abnormal cells then can be turned into cancer. It's about a 20-year process from being exposed to human papillomavirus that you can get cancer. The majority of people will not get cancer. It will be cleared. So I think one of the things that as a pediatrician and as a gynecologist we do is we offer the HPV vaccine. Mm-hmm. Starting at age 9 to age 45, you can get this HPV vaccine. There are a couple different types of vaccines that are out there, but it's protecting you against the high-risk forms of HPV that cause cervical cancer, and also some of the low-risk forms of HPV that cause warts, so genital warts. We encourage people to start this vaccination process when you're kind of 9 years old and entering into like a middle school before you get exposed to HPV. There's some data to suggest that we can give this to our cancer patients also, or our dysplasia patients that have been exposed to HPV, and perhaps it could improve the immune system's response to the virus that's in the body. HPV vaccination has been around for 20 years now. It is highly encouraged. I will get my children vaccinated, both my daughter and my son. Okay, so to think that your sons are not at risk for this would be wrong. Okay, your sons are the ones who are probably going to give the girls the HPV. So we can't treat half the population. Yeah. So both men and women, boys and girls need to be treated. Okay, men are more likely to have head and neck cancer. So if we can decrease their risk of head and neck cancer, potentially with the vaccine as well. So early vaccination, therefore the thought is to eventually eradicate the role of, or not eradicate it, but decrease the incidence of cervical cancer. Now, with that being said, how do you screen for cervical cancer? Well, the American College of Obstetricians and Gynecologists, we kind of back this process where you start screening at age 21. Not at first sexual encounter, it's really 21. Why? Because we know that these beautiful people are going to be exposed to HPV, right? And so they're going to have an HPV positive test come back, or they may have some abnormal cells. If they have abnormal cells, what are we going to do about it if you have an 18-year-old? Are you going to cut out part of their cervix? No, because 80 to 90% of these people that have HP are going to clear this virus, and it's not going to become a long-term problem. So why are we going to start screening at such a young age when the risk of cervical cancer is so low at that age? So we start screening at age 21, okay? You start screening, and if you have an abnormal pap smear, we wait almost 2 years before we do any sort of excisional procedure of persistent HPV if they're in their 20s. So we give them quite a while to clear their virus. Now, a lot of people ask this question, how do I clear this virus quicker? What modifiable risk factors? What can I do to decrease my risk of exposure or some of the side effects, or to get it out of my system? And one of the things that you can do is wear condoms. Even though if you're on a birth control, wear condoms. It decreases transmission rate of HPV. You have to remember, however, that HPV can be on the scrotum and it can also be on the vulva. Okay, so there can be transmission in that way. What are the modifiable risk factors? So wearing condoms, not smoking. Smoking increases the virulency of the virus and increases your susceptibility to HPV. So we encourage people not to be smokers. We talk to them about smoking cessation. We encourage them to wear condoms, not smoke, and eat a healthy diet. Those are really the only other things that you can do. And then come in for your pap smears. Don't get lost in the system. Make sure if you have an abnormal pap smear that you're coming back every year for your pap smears. It is recommended that if you have a history of abnormal pap smears, that you have a pap smear every year for the next 20 years. If you have a history of cancer, same thing. Cervical cancer, same thing. So you may not fall into that every 3 or 5 year group because you do have HPV and you do have a history of these abnormal cells. So you might be in the higher risk group that you just need to pap smear every year as opposed to 3 years and 5 years. Now, when your doctor says, hey, you don't need a pap smear for 3 years, that doesn't mean you don't come in for 3 years. That means you come in, you get an exam, you get a visual, they still do a speculum exam, they still look at the cervix, make sure they don't see anything, they inspect the vagina, they inspect the clitoris, they inspect the vulva, they want to inspect your abdomen, you want to have a breast exam. So what does it mean to have a well woman exam? Mm-hmm. A well woman exam is for you to come in once a year. And I think that there are a lot of misinformation of what that means because it's tied to your pap smear. Doesn't mean that you come in at a 3-year interval or a 5-year interval, because you have other things that need to be addressed on a yearly interval basis.
I agree with that, because in our pediatric world too, we tell parents, even if they're not due for vaccines, they still come in for a well baby or a well child, then a well adolescent, which we kind of build that into a lifestyle thing. Because
it's a lot of preventative medicine, right?
Yeah.
So how do you prevent things from cropping up? Mm-hmm. So we do breast exams. So we palpate the breast, we palpate underneath the arms to make sure there are no lumps or bumps. In girls that are developing, you can have cystic breast, you can have fibrocystic breast, you can have dense breast tissue, and you want to teach them, hey, this is normal, what's not normal. You also want to look for any rashes. Some girls may have very pendulous breasts, which mean that they are hanging and they may start to get some rashes underneath their breasts. How do you treat that? Talk about a supportive bra. Some people, they're not being raised by other women. Maybe they don't know. Maybe they have a dad and he doesn't know, or grandma doesn't know. You want to talk about posture. You want to talk about how you hold yourself. You also want to do a cursory exam, like feeling their groin lymph nodes, making sure that their pubic hair is coming in. You want to do a staging of their hormones. And so there's a lot of things that you can do in a well woman exam that doesn't necessarily involve a pap smear.
And so some of these things overlap, like your pediatric provider or your family provider can kind of start and transition the adolescent, and that'll lead into a normal practice of then going to a gynecologist.
Yes.
So having said that, when would that transition take place? When do you start getting your full gynecological care with a gynecologist?
So I think if your pediatrician is uncomfortable with some of the GYN symptoms you're having, that might be something to discuss with them. Also, if you're considering getting an IUD for cycle control, that might be something you see a gynecologist for. And there are specific adolescent gynecologists in the area that can help you. Also, girls that have a lot of pelvic pain, maybe the sign that they have endometriosis, maybe they have a big cyst. Ironically, I operate probably on about 3 to 5 girls every year that have something called an ovarian torsion, where they get a cyst on their ovary and their ovary turns and it becomes a surgical emergency.
Wow, that's more common than I thought.
Yep.
So they'll have that excruciating kind of side pain.
Yeah, and everybody thinks it's an appendicitis, and they're like, oh, you have a big cyst. Oh, there's no flow to the ovary. Oh, this is an emergency. We need to kind of flip this around so that we can save this ovary. Otherwise, you might lose the ovary.
If you were in that much pain, you would probably be in an emergency room.
Absolutely.
So that's something they would look into.
Absolutely. Severe pain. It could also be colicky, where it kind of untwists and twists again. So that might be something to consider. Go see your physician.
Yeah.
Okay. And they or go to the ER if it's so bad that they're in severe pain, they can't walk. They may have, the ride to the ER might be excruciating to them. And that tells us that that's a surgical abdomen, that something's going on that shouldn't be going on.
Yeah.
So you want to always keep that in mind.
There's a lot of things that could be happening in a young reproductive system.
Right. And so we said when to transition to a gynecologist. I think it's reasonable at age 21 to kind of start going to see a gynecologist, get your first pap smear, have a breast exam. And here's the other really important thing. Have a history taken, okay? You may not understand what your history was when you're a child, but when you're a 21-year-old, you could vote, you could drive, you could drink. Know your history. Know your family history. Know if you're at increased risk for any malignancies. Know who's died in your family. Know who had cancer. Know who had types of medical conditions. Because it's really important to know that information. When we talk about 30 years ago, people never talked about that.
Yeah.
Talk about your history. Now we live in a day where we have 23andMe, right? Like the genetics, you can do your own genetics.
Right. They do have a full, pretty comprehensive list. Yeah.
I've had a couple of patients come in, and that's how they figured out that they had a BRCA mutation through that. So it's very interesting to know that the science has really moved along and the public has caught up with it. But know your history, because it makes our job as a clinician easier to be like, oh, this person is at risk for this, or really find a doctor you can talk to. Talk about your history, talk about whatever symptoms you're having, and feel like you are being heard, because you're allowed to be heard.
You're going to have a conversation and to have yourself taken care of. Yeah, regardless of which kind of doctor, they should always be listening to you.
Absolutely. And if it's not their field of expertise, they should be directing you where to go. Because that's their job as a steward, as a mentor, as your doctor, to say, oh, that's not what I do. You know, well, let's get you to somebody. Let's have you talk to your primary.
Some of the best doctors are those who know what they don't know.
Yeah. Absolutely.
Yeah.
Because there's so much to know.
Yeah.
There's so much to know, but how about we've kind of taken a little snippet from every single field, right, that we've rotated through as medical students. And so we might not know the best way to work something up, but you know what? I know who I have to send you to. I know this is going on. This is where I think you need to go.
Exactly.
Point them in the right direction.
Yeah.
Because at least we have that extra training where we can rely on
that.
Yeah,
you know where to turn to. And we have colleagues that we can speak to. Yeah. Like I'm speaking to you right now.
Exactly.
In the call house.
We can
have the doctor special on HGTV.
We should. Like, what was it when they had the houses where you went to your neighbor's house and you flipped that? So maybe I'll do your room, you do my room.
It sounds great.
Like a flip or flop.
Right, exactly.
Yeah. I think when we talk about PCOS, what is PCOS? PCOS is a syndrome. So you have a constellation of symptoms. What happens is that there is a lot of estrogen being secreted, from your ovary, and it causes you to not get your cycle, or to get your cycle very erratically. So you might get your cycle 1 month for 4 days, you might not get your period for another year. You have a very irregular cycle. Polycystic ovarian syndrome also comes with this metabolic kind of syndrome where you can have obesity associated with it, insulin resistance, you could have facial hair growth. It could be really very difficult for girls to kind of experience some of these things.
And get more acne sometimes.
Acne, yeah. Oftentimes it can be controlled with hormones. So putting them on a low androgen kind of hormone, and there are hundreds of different types of birth control or OCPs that you can use this. One that maybe has spironolactone based, so that you can deal with some of their insulin sensitivity. You also want to make sure that they're on a good nutrition plan, because you don't want their weight to spiral out of control. You also want them cycling regularly so that they don't have this buildup of estrogen, which then can lead to an increased risk of abnormal cells inside the uterus. If you have them on the right pill, it can help with their facial hair, it can help with their acne, and it can help with cycle control. This is almost like a multidisciplinary approach is required to treat this disease. So you want to make sure that they're nutritionally sound, that they're following probably a lower carbohydrate diet, like similar to almost like a pre-diabetes diet. You want to make sure that they have physical activity. Often PCOS is treated with metformin. I don't know if that would be something that you would be comfortable treating, or something that
like an endocrinologist
may consider seeing them and treating them.
Yeah, sometimes endocrinology overlaps with our adolescent gynecology issues.
Yep.
Because of reasons like insulin resistance or even thyroid problems.
Absolutely.
Another thing I wanted to quickly touch on, irregular periods and a potential thyroid problem in our teenage girls.
Absolutely. You might see some issues with their hair growth. They may have thinning hair. Mm-hmm. They may have weight gain. They may have irregular cycles. They may have like very dusky looking skin. Mm-hmm. So there are a lot of side effects to thyroid. They're all kind of secreted from a gland that makes different forms of their hormones. So they kind of have some of the similar side effects.
So when there is a girl that's having some irregular periods and maybe kind of trouble, like other kind of systemic, like other problems besides the period, it's good to think about these two
Absolutely.
kind of things.
It's not necessarily just one thing that's going on, and it could be a side effect from them. So absolutely, I think you start with your pediatrician. Make sure you're being heard. Make sure they're listening to you. And then if you need to go to a gynecologist at that point, then you might be going to gynecology and endocrine to figure out what's going on.
And we do. We work with doctors. I think the gynecologists are the group I work with the most out of other specialties because, well, first of all, we see each other at 3 o'clock in the morning on Saturday.
That does it, the high fives.
Hey, let's have this baby now. Then there's so much overlap. It's women's and children's health is always the term for it.
And the other thing is consider pelvic ultrasound. Okay, check out and see what their uterus is doing. Hormones are not really super helpful unless, you want to check a pregnancy test to make sure they're not pregnant. So if you're not getting your cycle and you're sexually active, always check a pregnancy test.
Yes, it's pretty easy to check.
Yep.
It's a quick dip.
And you'll find out.
You'll find out, yeah. Mm-hmm. Okay, well, that was a great
diatribe.
We learned a lot today. Like we were saying, it starts with girls into it's going to be the rest of your life, right?
Your menses is often called your curse.
Yeah.
And so I don't think it is a curse. I think that it is what makes us so special and what makes us be able to carry life. What makes us able to give life.
Which is probably one of the strongest and difficult things any human can ever do.
Yes.
Is carry and give birth. And then being a mother
is very hard.
Very hard.
Here's the thing. Anybody can be a mother, right? So anybody can be a mother. But really being a good involved parent and listening to your child, because getting pregnant is the fun part. But being there and really, this, you're the pediatrician. You see this every day.
I see the tired, the overwhelmed, the stressed mothers, the teary mothers.
And as a mom, I will tell you, I struggle every day being the best version of myself to my kids.
Right.
Like some days I'm a great mom and sometimes I'm on it.
Right.
And some days, here's your iPad. Here's some days like I just can't because I'm a human being too. And like you try your best, but you have to be real. You have to I'm a busy surgeon. I'm a busy doctor. I give everything I can to my patients. I try to give to my kids. The interesting thing is that my husband, who is a retired policeman, actually is a disciplinarian. And so I get to be fun mom. You know what I mean? So, which is really usually the opposite of what goes on because mom usually... So my husband's a stay-at-home dad and he has the rules. Yeah. And so I get to break a lot of the rules. So it's lovely.
So it kind of makes sense with your personality. Yeah. You're chill and
I'm a little
police
bit more
officers.
Chill. Rules. And I mean, they have rules. They make their beds. They have chores.
Which is good.
Yeah. And so I'm thankful that I have the yin to my yang that can parent that way and hey, you're giving them too much.
You gotta have a support and help. Like I always say, which is why I have this podcast in the first place, that it takes a village. It's not just the mom, it's not just the dad, it's all of us. Yeah. I don't have kids, but I'm very much involved with the raising of these kids. Yeah. Why is that? Because the pediatrician's important. It does take everybody.
We see our pediatrician when we take our kids skiing.
Right.
We see I'm like, hey,
Yeah.
You know?
Yeah.
He's like, how are they? You know?
And no matter what you do,
Mm-hmm.
no matter where you are around town, you got to make a good impression for these kids.
Yeah.
Yeah.
It is a small world, and I didn't realize how small my world was until I opened my new practice, and word of mouth that you listen, that you're kind, your staff picks up the phone, you're somebody who can be relatable, that you sometimes wear leggings because you're tired. Sometimes you wear your hair in a ponytail a couple days in a row because, like, you didn't have a chance to wash it this morning.
Right.
You know what I mean? Like,
washing your hair takes a lot of effort.
yeah, you are a human being, but you come to work and you try to bring it every single day. I am happy that my daughter can see me work as hard as I can. You know, some days, Mommy, why do you have to go to work? Well,
yeah.
Mommy has to take care of these sick ladies.
Yeah.
Mommy has to do this. Mommy's delivering babies this weekend.
Yeah.
I think it shows her a really good work ethic.
It's a great work ethic because you're still there. And that's really important.
Yeah.
Yeah. You're still a present parent.
Yes.
It's such a challenge, but you make it happen.
Yeah. My nephew, who's 21, he and his girlfriend are having a baby. And so my first reaction was like, oh my God, like, you're too young. I had my first baby at 38. Like, I was a doctor. My husband was a policeman. We were pretty established.
Right.
Okay. I had to get over my own stigma of, like, that wasn't my path.
Right.
But, okay, your path is different. Everybody has a different path.
We do tend to, like, without meaning to, we do have, like, these set ideas of what should be done.
Right. And so he had told other people and he didn't tell me. He lived with us for a couple of years and I adore him. I really helped him out when he was a teenager because, like, he was struggling. He was like, I wanted to tell you personally because, you know, I'm moving to Albany. I'm going to be around. That was really a shock for me, and I was putting my own values on him.
Yeah.
But kind of to go back to your opening, it takes a village. And at 38, I still needed my mom to come help me watch my kids.
Oh, yeah.
I still needed friends and family to help me. And to this day, we still do.
Yeah.
So it takes a village to raise your kids. Okay? And just like that, I'm going to be helping him with his kids because I'm part of the village.
Right. Yeah,
So-
exactly. In this scenario, you're a different part of the village. You're not the mother, but you're the great aunt.
Yeah.
And you're the neighborhood OBGYN.
There you go.
That's
so
a
it's
convenient
funny
aunt to have.
because a couple weeks he had asked me, "Oh, Bailey needs an OBGYN," and I'm like, "Oh, this person." I didn't even think because it
Why?
wasn't even
Yeah.
on my, like, radar to be like, "Oh, this is what's going on,"
Right.
you know. And that's my own prejudice, my own bias. But
Like, you wouldn't think that would be in your world.
right,
Right.
Yeah. But it, you know, a baby is a blessing. A baby
Yeah,
is a gift.
baby-
So it's an exciting moment. So
Yeah.
I know it's so you know, you never know what
It's-
comes into your life.
Yeah, and now it's not you as the doctor, but you as seeing this baby and all
Yeah.
these thoughts that are going to happen.
Yeah. So I'm excited.
Yeah, it's exciting.
Mm-hmm.
Great to chat with you. And
You too.
thank you so much. This
It's
is
my pleasure.
like audio gold here.
No,
having
stop.
a conversation.
It's an important topic, and I think that we need to keep talking about it.
Yeah, absolutely. And we will. This is the beginning. We're going to be hearing a lot more from
Part 1.
from Heidi.
It's my pleasure.